Welcome, Professor Reina, to the Duval Clinic. It's a pleasure to welcome you here.
Thank you.
As you may know, the Duval Clinic is my main facility where I work for more than a year now, full-time. I was an academic surgeon and working here part-time before. We do only hip and knee replacement at the clinic. It's a dedicated small hospital only for joint replacement. So we have 2 ORs, but only one team. So we work with the 2 rooms, but only one anesthetist, one nursing team, one surgeon, and we do about 1,200 joint replacement per year. It means about 5 to 6 per day, 5 days a week.
I wanted to know who you are actually.
My training in orthopedic surgery was done in Quebec province, Canada, and then I did a fellowship in Australia. Mainly to learn hip resurfacing, ceramic hip replacement, and revision knee surgery. I worked for about 22 years as a professor of orthopedic surgery, doing research, teaching, and also clinical work. I received the title of researcher from a public institute in Quebec, so supporting academic researchers.
So after 22 years in public sector, you moved to the Duval Clinic?
I'm working in the clinic for about 15 years since its foundation, but I was working part-time, really in period of the year, a few, let's say 2 months per year, but most of my practice was academic. So I decided to move 100% in the private sector at the Duval Clinic about 12 months ago.
Okay. So what is your typical week?
Currently, since I'm working at the Duval Clinic, I would do about 2 OR days, operating 5 to 6 patients per day, so about 11, 12 per week. And I would do 2 days of consultation with seeing the patient before surgery or after surgery. Typically, we see about 12 patients per day in a preoperative period, spending 30, sometimes 35 minutes per patient. And as a medical director of the clinic, also I spend a lot of time organizing the care at the clinic. I'll try to be a leader for the teams, nursing, physiotherapy, anesthetist, general practitioner, to get really all these people working together to provide the best care possible to our patients. Yeah, we are a team of 4 surgeons working at the clinic. I'm the only 100% here. My 3 other colleagues are opting in and out, public and private, as I was doing before. So every day we are 2 surgeons at the clinic, one who's consulting, one who's operating. In Canada, so many patients are waiting to get their surgery done because the waiting lists are a year, 2 years. So most patients who come here, they are coming from different provinces of Canada. We have our assistant, Philomena and Anna, who will assess all the documents sent by the patient, their X-ray report, MRI report, a reference from a general practitioner. They will understand if this patient is a good patient for the clinic. Once they've made this assessment, they will create the appointment. So we have a very, very tight, let's say, selection from the base. We'll see our administrator to receive a proposal of a care episode. If they accept, the same day, they will come and see our clinical nurse, get an EKG done, blood test, receive all the information to prepare himself for the surgery, and also fill an exhaustive health questionnaire. The patient will see the general practitioner to optimize all comorbidity, to prepare the patient to be at his best status before surgery. So anemia, heart disease, high blood pressure, You think about also renal insufficiency, prevention of urinary retention. All these things that are modifiable will be taken care before the operation. If ever some of these disease require a bit more time to be optimized, we will delay surgery. A patient with hemoglobin level a bit too low, scheduled for bilateral hip surgery, we want the hemoglobin level to be above 130, so he would receive iron, maybe erythropoietin, and we will do a check on the hemoglobin level, let's say 3 weeks later. So, Nicolas, when I assess a hip problem, I'm an arthroplasty surgeon, so I'm looking for hip degeneration that requires a hip replacement. 3 sources of pain are very frequent. Pain on the lateral side commonly is from the greater trochanter bursitis, tendinitis, and pain in the groin is very specific to joint disease. When we examine the hip, I start patient laying down. I will palpate lower back, lateral side, and then I would like to do a LASIK procedure, say if they have irradiation below the knee. Any pain below the knee is not coming from the hip. It's from the sciatic nerve or femoral nerve. I will bend the hip and then do the flexion, adduction, internal rotation test. Simple maneuver, just let your hip going and then making this movement with more internal rotation.
In many cases, you have people, they have this kind of pain, but they also have for example, bursitis or back pain. And sometimes it's difficult to see if it comes from the hip or associated pains from all around.
In people that gets older, you have many patients have a combination. They have lumbar spine disease, trochanteric bursitis, and intra-articular disease. This is my role to teach them origin of the 3 different sources and to tell them if I do a hip replacement, it will solve probably only the groin pain. Sometimes lumbar spine pain is related to stiffness of the joint. So people, they have a stiff hip and they walk with the pelvis or they sit wrong and then they create a lumbar spine disease. These patients, there is a recent paper showing that when you treat the hip, 70% of the people have reduction in their lower spine pain. And lateral side tendinitis, we know most people, it will heal by itself. And if the tendinitis is secondary to limping from the hip disease, it may be cured by the hip replacement as well. In my practice, 95% of the patient, the indication is disabling pain every day and preventing patient to do their daily life activity. Our first tip of the day, Nicolas, will be a hybrid hip replacement with dual mobility articulation, a cemented stem, smooth finish. Believe that an anatomical diameter joint is favorable for patient recovery, function after surgery because they can return to any type of activity without restriction and the fear of instability. I can adjust leg length much easier with a more stable joint than a 32, 28 or 36 bearing.
Small room, which is a prep room?
It's a preparative room where we have here inhalotherapist, a nurse, similar formation that is the assistant of the anesthetist. She will bring the patient, make him comfortable, warm the patient, put nice music, put the IV in, and start the process to prepare the patient for the surgery.
And that's not only this, you work a lot on the anxiety, right? And the fact that the patient is calm before getting into the OR.
It's very important. This caring that we do is a game changer for the patient experience. A patient that is not stressed will have less maybe side effect, will respond better to the treatment, and will have confidence in the team. That's something that play a big role in the clinic here. And most patients when they come back to see us after 4 to 6 weeks, they give us this testimony and say, oh, this was fantastic. So I start 2 finger breadth from the tip of the greater trach. I want to be oblique and posterior. I will use the 2 ends of the incision, one for the acetabulum, one for the femur. It will be similar to this. And so I take the gluteus maximus. I want to protect the vastus lateralis. We use curved reamer to minimize impingement, and I get my proper alignment. And this is the cup we use, dual mobility with macro texture. Good bone, very happy. Now we'll infiltrate a local anesthetic into the joint, 400 milligram of ropivacaine. We'll use 50 cc for the deep part. I inject all around the acetabulum. Even I try to do a block anteriorly, and for us, standard hip replacement, fixed bearing is 0. We use dual mobility for all our older patients, 65 and older, and we use ceramic on ceramic large head for all the younger and more active. So it's large diameter bearing for all patients that come to the clinic.
Yeah.
Juste-moi l'épaule un petit peu. Non, ouais, c'est ça. C'est congruency. Leg length is the same as we expect, and very stable. This pivoting of the joint, and then we're ready to close the capsule. Interesting that the stability of these joints is great if you have soft tissue healing. We inject the 3rd syringe into the muscle, bursa. Want to really have a strong closure, because the patient in the post-op, they are recovering fast. They have little pain. So sometimes they go on the bicycle after 2 weeks, 3 weeks. They pedal hard, and I want this fascia to be really, really tight. And you want to minimize the risk of anemia at home. Here at the clinic, we keep patient 1 or 2 nights, so we control their hemoglobin on the day 1. So we put the glue. It's a dermabound. It's a glue that will seal the wound. It takes about 2 minutes to get cure and hard, and then we will put the small dressing. Yes, right? We do the X-ray in the recovery room as a safety measure. Make sure everything is okay, no fracture, no malposition. He will stay about 20 minutes, go to his room on the 2nd floor that we will visit later today. And then he will start physio about 2-3 hours after surgery. He will be able to stand and go to the bathroom, start the exercise. And usually they stay 1 or 2 nights at the clinic, depending on their age, their mobility. And they continue their exercise program at home. Which we give them, and then anytime if they have a problem, they can contact us for advice, or if there is a problem. We try to do an opioid-free procedure or minimize opioid use. Especially for hip, we can achieve this in probably 90% of the patient, and so we do multiple measures to prevent pain and to control pain in the first 24 to 36 hours, where there is the storm of pain usually if you don't do anything. If we're good at controlling this first 24 to 36 hours, patient will not require any opioids, and then will avoid all the side effects associated with these opioids. Here in the recovery room, if the patient feels comfortable, we don't give anything, and this is majority. If they have some pain that they feel uncomfortable, more than 3 or 4 out of 10, we will suggest to use a tablet. So start with a tramadol or oxycodone, but only in tablet. We try to avoid at any cost any subcute or IV drugs. I think pain control is the key of success of what we're doing. Ça va, vous?
Oui, ça va.
Bien, excellent. On va faire la petite photo pour voir vos hanches.
Merci beaucoup, docteur.
Écoute, ça a bien été. Hein? What we did here is a dual mobility joint replacement, cemented stem. We tried to reproduce anatomy of the hip, offset, leg length. I did your hip. Everything went well. There was a lot of disease in his hip. We have a prosthesis that is well fixed, solid. This afternoon, you will be able to stand, put full weight on your hip. If you're hungry, you'll be able to eat, and you'll go to the bathroom, walking with the therapist.
Yeah.
And I will go and see you at the end of the day. Now you're 5 minutes out of the operating room.
Yes, and I can start feeling my legs,
Already.
and doesn't hurt at all.
Yeah.
Doesn't hurt at all.
So you're able to move your feet very well. Can you bend your knee?
You mean like this?
Yes, yeah. Okay.
Absolutely.
Okay. So then no pain.
No pain at all.
Put it down and then raise straight like this. Yeah. So this is nice because now we have full muscle control, no pain, because we have local pain control.
Yeah.
The anesthesia was short acting, 45, 60 minutes, and now he will move his feet, prevent blood clot. He will have less risk of orthostatic hypotension. She's 60 years old, very, very fit and active lady. She's a grade level 4 skier. We proposed to this lady to use a large diameter head ceramic on ceramic bearing with uncemented implant. Quite similar for all patients. For sure, more muscular, bigger patients, I need to use longer incision. The cup we use is a titanium shell with ceramic insert that has been assembled in the manufacturing process. So it comes as a monoblock cup. No screw holes, impossible to supplement fixation. That's why the reaming process is very important. You want to create an hemispherical shape, and then it may become a bit more challenging in some dysplastic hip, Perthes disease, and you learn over time how to create this hemispherical shape. The patient can play tennis, running, jumping, and they don't complain of thigh pain. All the impact activity, tennis, jumping, running, weightlifting, we wait 2 to 3 months.
Okay.
No crutches. People use a cane. Most people use the cane for about 2 to 5 days, sometime a week. The better we are with our ERAS program.
Yeah.
I mean, some patients, they do too much.
Yeah.
They feel too good. So we need to slow them down. So we will do the subcuticular and then seal the wound with some glue. And patient will be able to shower tomorrow morning. They will keep their dressing for 12 days. And it will reduce the workload of the nurses at home. It will reduce the stress of the patient if they have a clean wound, no wound discharge, no oozing, and no staples to be removed. I'm cutting my neck a bit higher, getting more metaphyseal fixation. So the depth of the reaming is okay. We're quite anatomical. We have about a 45-degree cup. So I'm very satisfied with this, and I'm sure the patient will be as well. We're not sure what was the best for the patient because you may know that I was a big proponent of day surgery in Canada. I did the first case in 2016, and when we started hip and knee replacement in private practice here, we believe that for the patient to stay in the clinic, there are much more benefit than going home. They have time to talk with the nurse. They have time to talk with the physio, learn the exercise. If they have concerns, stress, they are taken care of, and it's a safe environment. The bedding is nice, the food is okay, and we believe that it's improving the patient experience to stay with us 1 or 2 nights. Most people, day after surgery, they will walk with the cane, do the corridor, and start the exercise with the physiotherapist.
Oui, là, vous allez prendre vos deux mains par contre pour vous lever avec
OK.
la ouais, comme je faisais. OK, parfait. Fait. Donc, côté opposé à la chirurgie. Quand vous êtes prête, on y va. Comme ça.
And we have a team here of about 60 employees. But as you know, in a small hospital, it goes from the laundry, cooking, maintenance, and also the medical staff, nursing, physiotherapy.
I had the feeling, spending these days with you, that you are one piece of the whole pathway, but you're not above. It's like you, the surgeon, even if you are like managing everything, you are one piece, and everyone is very, very important. We have the feeling that you have included everyone in the pathway. So education of the care is important as well.
It is a paramount importance. You know, after 20 years of practice, I mastered my surgical technique, and I understood that to improve patient outcome, to improve patient experience, I need that all my team members do their best, and we bring this collaboration together to create the real experience for the patient. So what is the great advantage I have here in this private clinic is that my team are permanent. I have people seeing patient for hip and knee replacement every day. They become expert in each of them in their field. The inhalotherapist, the anesthetist, the nurse, even the attendant. So they will receive the patient in the morning of surgery, and they will know how to make the patient feel comfortable, give the proper advices, prepare the patient for surgery. So it is as simple as the person who will bring the patient from the room to the OR during the travel time. It is only one floor, but will create a relation of confidence. You will tell the patient, you know, you're in good hands. The team here is fantastic. You will have a good recovery. And the patient needs to hear these words.
You mean the wording has been studied, and like you have taught all the people what to say?
No, all these things appear because we have a team that the confidence between each team member just evolved by itself. You know, having a person that knows you for a year, 2 years, you work every day with them, the confidence build up. So the problem in public practice, in my experience, is that turnover of the people is so important that I was never able to create that confidence with my team member. And in public system, it's very easy to forget the patient, that we are there to treat them. And then now we see long waiting list. A person in Canada, if they meet an orthopedic surgeon, will be told that there's 12, 18 months of waiting time to get their knee fixed or their hip replacement. It is too long. It is unacceptable. So we need to refocus on the patient. From the early days of my practice, I always focus to offer to the patient a forgotten joint. This was my goal. On the hip side, you know, my early research was on hip resurfacing, large diameter head. And I think I reached a level of satisfaction from the patient regarding the midterm function, the return to normal life. Then I focus on the peri-operative period, ERAS protocol, reducing pain, reducing the motor function loss, making the patient going back to work earlier. So this is really in the last 5-7 years, my focus was on the enhanced recovery after surgery. And I think with the hip replacement, the gain that still needs to be done is quite marginal. We have a mature surgery. On the knee side, very different. I mean, the gain to get on the knee side are major. So on the knee side, that's why I focused a lot in the last year to create this personalized arthroplasty society. After 20 years in my practice, I felt that if I want to continue my goals, to feel satisfied in my practice, it was to come to the Duval Clinic to continue my career. And I made this decision, which was very difficult. You know, when you quit partially your academic practice, which invest a lot of time, it is something very hard. Took me 2 years to make my mind, but it was probably the best decision I made ever.